Good morning. I want to welcome everyone to the Seminole Institute UCLA Child and Adolescent Psychiatry Grand Rounds. I'm very proud to brag that I helped recruit Dr. Emily Wood first to our adult research track and then to our child research track. She came to us with an impressive background, having completed multiple undergrad honors theses at the University of Washington and an MD and neuroscience PhD from the Medical Scientist Training Program at Johns Hopkins University and the NIH. During child fellowship, Emily worked with Mirella DiPreto and Shula Green using functional MRI and MRS methods as part of a multidimensional approach to better understand resilience to trauma in individuals with autism spectrum disorder and a history of early life adversity. Emily has so many achievements that I can cite, with multiple publications, national and international presentations, and research awards, including the prestigious NIMH Outstanding Resident Award and the UCLA RITVO Award for the fellow with the most promise as an academician and researcher. She's even earned her own funding, including the ACAP Pilot Research Award and a philanthropic donation. But Emily is more than a research rock star. She's passionate about child mental health and fiercely dedicated to her patients. She's a dynamic teacher, inspiring mentor, and generous member of our community. But what I admire most about Emily is that she has a strong moral grounding and fearlessly stands up for what she believes is right. I'm always inviting her to help me recruit people to our programs because she is everything we hope to nurture here at UCLA. I'm so very proud to be one of her mentors and thrilled to continue to be her colleague as we've managed to entice her to become UCLA child faculty starting in July. I can't wait to see what's next and to hear about her research today. Emily.
Thank you so much, Erica. That was very kind. All right, so you guys should be seeing my first slide. I'm gonna move thing over here. Okay. All right, so thanks so much for inviting me to talk. The bulk of this talk will be about post-traumatic stress disorder in youth with autism, and I got that data from the ABCD study. And then I will also talk a little bit about some other work I've done and some future projects. So, and before I say anything else for this project, I'd really like to start by thanking an undergraduate who worked with me on this project, Jillian Melbourne. She's great, and she graduated last year, and I'm so proud of her. And then, of course, Mirella DiPreto, Shula Green, and Susan Buchheimer are wonderful mentors who I'm so happy and lucky to be working with. So I have no disclosures, and I'm told that the Q&A will be available throughout the presentation, and that you can post questions there, and we will discuss them at the end. And the Q&A thing, it should be like at the bottom of your screen, and it should look like this. And also, I love using the design ideas in Google, in PowerPoint. So, so that's how these slides are made, and if they don't seem to match, sorry. And then finally, one more thing, if someone could tell me if the gardening that seems to be happening next door is very loud and I should put in my earbuds, that would be great. Let me know. So we'll talk about a little background about the topic, my results, discussion, some ideas I have about broader implications, and then a little bit of my past and how this leads into my future research. And for background, I want to just briefly discuss autism spectrum disorder, ACEs, PTSD, and the ABCD study. So this crowd should know what autism is, but it's always important to really break it down and remember that while it does encompass, these core deficits of social interaction and restricted repetitive behaviors, it really is a very heterogeneous group of males and females with wide-ranging IQ, verbal ability, and daily functioning, who just share these deficits in social interactions, such as poor eye contact or difficulty holding a conversation, and may have restricted or repetitive patterns of behavior that include sensory sensitivities. Adverse childhood experiences, or ACEs, are a range of early life adversity, such as neglect, abuse, and household challenges. And a large number of research projects has shown that the number of these experiences, more experiences has been associated with poorer both physical and mental health outcomes in adolescence and adulthood. So you can see here, we're talking about both physical and emotional abuse, neglect, and some other, sorry, I'm trigger happy here. And then other areas of household dysfunction that are very stressful for youth. Some evidence suggests that youth with autism experience more ACEs and trauma than their peers. Deficits in communication and emotional expression skills in people with autism may lead to higher rates of interpersonal trauma, such as bullying, as well as higher rates of physical and sexual assault and caretaker abuse. It is also possible that problems related to restricted and repetitive behaviors, including behavioral rigidity, difficulty with changes in routine, and atypical sensory experiences could lead to individuals with autism developing post-traumatic symptoms following events that neurotypicals would generally not identify as traumatic. And it's important to remember that though exposure to trauma is a diagnostic criterion for PTSD, not everyone who is exposed to trauma develops post-traumatic sequelae. And we know that everyone has different resiliency mechanisms. That being said, to receive a diagnosis of PTSD, one must have a number of symptoms from each of these categories, including exposure to actual or threatened death, serious injury, or sexual violence per the DSM. We can imagine that having some of these symptoms without fitting all the criteria still suggests a chronic impact of a traumatic experience. The Adolescent Brain Cognitive Development Study is the largest longitudinal study of brain development and child health to date. Investigators at 21 sites around the country are measuring brain maturation in the context of social, emotional, and cognitive development, as well as a variety of health and environmental outcomes. We chose to source data from the ABCD because it includes behavioral assessments, including diagnostic inventories, measures of adverse childhood experiences, quality controlled resting state fMRI imaging data, and a large cohort of nearly 12,000 participants. We were interested in studying the effects of ACEs on trauma symptoms in youth with ASD. So then going into my results, I'm going to talk about the demographics of this group that I looked at, their adverse childhood experiences and PTSD symptoms, some regression analyses of those behavioral measures, and some functional connectivity resting state fMRI analyses. So we defined our ASD sample by parent-reported autism diagnosis at study screening and found 201 ASD youth, which happens to be 1 in 59 out of the whole ABCD study participants. And that number is interesting because that's actually the recent number out of the CDC, about 1 in 60 for how many people have autism. After exclusion based on missing data and siblings, we had 192 remaining, from which a control group of 5 to 1 typically developing to ASD peers was established using a nearest neighbor matching protocol that used gender, age, IQ, socioeconomic status, and MRI scanner. As expected, given the higher rate of autism diagnosis in males, the group here has a lower percentage of females than the full ABCD study. This would be the whole 11,000 kids. But because we matched on these things, age, IQ, SES, you can see that there's no significant difference between the two. There was also no significant difference between groups in terms of the breakdown of race and ethnicity. So the ABCD study was not designed to study autism, and that became very clear once I started to evaluate the data and try to figure out which kids had autism. So luckily they did have, like I said, the parent report of autism diagnosis, but we wanted to sort of substantiate that and make sure that that made sense. It was a little bit hard because even though they did the KSADS they did the full KSADS for DSM-5, they did a very abbreviated neurodevelopmental module. So they really only asked 3 questions. And you can see that just asking about unusual body movements, strict routines, and poor eye contact, it does not an autism diagnosis make. Nonetheless, the kids who parents said they had autism had way more of these symptoms, and the kids whose parents said they did not have autism mostly had 0 symptoms. And then they did a shortened version of Constantino's social responsiveness scale. And once again, we see that the kids with autism have these much higher elevated social problem scores, whereas most of the kids in the who were considered typically developing scored in an average normal range for this. So that's helpful to see. And just given our interest in sort of understanding the effects of trauma in ASD youth who are known to have high rates of comorbid ADHD, anxiety, and depression, I did select some CBCL subscales for attention problems, the anxious depressed, the withdrawn depressed, and then the externalizing and internalizing behaviors to characterize this group more broadly. You can see that across the board in purple that the ASD group has significantly greater T-scores on all of these scales. I assessed all of the behavioral health and cultural measures collected by ABCD and assigned items into 20 ACE domains. These domains were based on revised ACEs framework from the World Health Organization and implementation of studies of ACEs screeners in pediatric primary care settings. The domains are known stressful and traumatic experiences for kids, including physical and sexual abuse, family and household stressors that we talked about earlier, familial mental health, problems, neglect, and you can see here that there was a measure of school instability. There were also measures of housing instability, so whether or not children experienced having to move a lot, food, whether or not they ever were food insecure, things like this. Interestingly, ABCD did not start collecting any bullying data until the 3rd year. So I don't have any of that data because this is just from the baseline and 1-year data. Because we know that's interesting because we know kids with autism experience a lot of bullying. And so what I did was I just assigned all of the items I could get to these domains, and then I gave everyone a score that was their number of items in that divided by the max score that anyone had in that domain. And then to get a total ACEs value, I just added those normed scores together. Now we can start looking at some of that data. So here we see that, as has been seen previously, individuals with autism spectrum disorder have significantly more ACEs than their typically developing counterpart. I think it is a little hard to tell with these blobs, but there were more ACEs in the ASD group. Additionally, nearly twice the percentage of individuals with ASD met DSM criteria for PTSD, so that's shown here. So it was about 10% in ASD, where it was 5% in the typically developing group. And then this is important to note that because of the way the case heads is done in these studies, they ask questions, and based on that question, the answer to that question, they'll decide whether or not they need to ask more questions. So in this case, they asked whether or not there was a DSM-5 criteria level trauma history, and only those who said yes then went on to have the rest of the PTSD scale. So here we see that there was a significant difference, that more kids with ASD had experienced a DSM-5 level trauma. And then looking at just these kids, the kids with, while it was not significantly different, you can see there's a trend towards the kids with ASD having more PTSD diagnosis in this group. And they were much more likely to have more than 0 PTSD criteria outside of the trauma history. So then what I was really interested in a way was, this relationship between autism and typically developing youth, how adverse childhood experiences leads or is related to post-traumatic stress symptoms, outside of just DSM-5 criteria trauma, and how autism might mediate that relationship. I had previously thought that it might be possible that for kids with autism, that the slope of the relationship between ACEs and PTSD might be steeper, and it was not. So using a negative binomial model for this PTSD count data, fitting for both the ASD and control groups, we see that as expected, with more ACEs, there are more PTSD symptoms, but there was no significant difference between the two groups. So then I looked at the CBCL measures to understand what other ways these groups might differ. And when you add into that previous model a variable for both externalizing and then also internalizing symptoms, you see an interesting thing comes out, which is that for the kids with autism spectrum disorder, they had significantly more PTSD symptoms related to more externalizing behavior. Whereas this actually alone for the typically developing group was a not significant relationship. This is above and beyond ACEs. Whereas for the neurotypical group, it was really related to more internalizing symptoms that you see for the PTSD symptoms. Whereas for the ASD group, there wasn't a notable increase in or relationship above and beyond ACEs for the relationship between internalizing and PTSD symptoms. So what, we're starting to build a model of some of the different ways that adverse childhood experiences may be related to PTSD symptoms, differently for ASD and TD youth. And here we can see that externalizing symptoms and internalizing symptoms are related differently. Now, the directionality of this is unknown. I think that these arrows pointing from adverse childhood experiences to PTSD have some fairness to them, but we actually know that kids with more psychopathology are also more likely to then be in worse situations down the road. So there's some going backwards. And we know that externalizing symptoms can get kids into bad situations also, and same for internalizing symptoms. So the directionality of all of this is unclear, and I can't see anything based on the data I have, but this is the model we're starting to be able to build. Next, I looked at the resting state functional MRI data, and we're not going to go into this, but in detail, they did I'm using the data from the ABCD study. So they did the main processing and then divided all of the resting state data into the Gordon Functional Atlas, which is like functionally defined parcels based on resting state correlations from a very large previous study. And then they resample that atlas to the individual subject space and use these blobs as seeds for the connectivity analysis. And I really wanted to, this was a little more of an exploratory part of the data. So I wanted to be really sort of narrow and think about what were parts of the brain that I was specifically interested in. And in this case, the amygdala is a key part of the emotion system, and we know that it is related to fear learning and is implicated in PTSD in many studies. So I wanted to understand what the amygdala connectivity was like. And then in this particular case, especially since my lab studies sensory overresponsivity, and because it is part of the repetitive and restricted behaviors aspect of autism, I wanted to look at sensory areas. For the Gordon Atlas, that is broken down into the visual network, the auditory network, the sensory motor hand network, and the sensory motor mouth network. And then finally, the salience network has been implicated in both PTSD and autism spectrum disorder. And I wanted to evaluate that as well. So those were the four sensory, the salience network, and then the connections between those to the amygdala were what what I studied. And when I say connectivity, what I'm talking about is the way that those parts of the brain fire together. And that's what we're measuring in functional connectivity, resting state, fMRI. So this is not necessarily directly applicable to anything about PTSD and ACEs, but what was really cool to see is that in this data that I grabbed from ABCD that was not designed for studying anything about this, was not designed for studying autism, I saw a relationship between amygdala and salience network functional connectivity that we have seen previously in our lab and that has been seen by other people. So that is greater amygdala salience network functional connectivity is related to worse social skills or higher scores on the SRS. And that, so that I think lends some support to these data. Being, I'm not just pulling out functional data from anywhere. These are good data that they collected with ABCD. Then I looked at the connectivity measures we were talking about. So I found that there really were differences in amygdala connectivity or aberrant connectivity between sensory areas and the amygdala for kids with ASD compared to their typically developing peers. So first, I saw a three-way interaction here with this right amygdala to visual network functional connectivity, where there was basically there was no relationship between this connectivity and PTSD symptoms, regardless of ACEs in the typically developing group. So this is, and just one more time to orient you, this is looking at connectivity predicting PTSD symptoms over and above ACEs. So ACEs is in the model. And in fact, there was a interaction with ACEs such that in kids with ASD, higher number of ACEs was related to more symptoms only really if they had greater amygdala sensory or visual network functional connectivity. And that same relationship overall was seen, but without an interaction with ACEs, was seen here with the amygdala to sensory motor hand connectivity. So in ASD youth in purple, more connectivity between the amygdala and this sensory region was related to more PTSD symptoms. Interestingly, the left amygdala looked a little different in that it really followed this other pathway over here for sort of lower ACEs, but in this case, there was no interaction, in that the kids with ASD who had less, in this case, we would say, it's a little bit annoying, but we would say more negative functional connectivity between the left amygdala and visual network are the ones who had the higher PTSD symptoms. Whereas in both of these, the control groups, there was just very little relationship. So now we've added some more parts to our model. Oh, and I didn't show you the salience network, but that there was also a relationship between the left amygdala and salience network functional connectivity that was similar to the left amygdala and visual network. So we're seeing that we're adding some parts to this relationship here, that there is some interaction effect between the connectivity of these regions and whether or not kids are more likely to have more PTSD symptoms. So to talk about this, this data, firstly, this is the first study to examine the prevalence of PTSD and PTS symptoms in a broad community sample of youth with ASD and typically developing matched controls. So while a number of studies in the past have looked at kids coming to centers for treatment of their ASD or their PTSD, and then analyses were done and looking at the rate of PTSD in these groups. This is the first to really look at just sort of a broad community sample that was collected for not any reason, but then had the data showing ASD and post-traumatic stress disorder diagnoses. And the value of about 5% of typically developing kids having a diagnosis of post-traumatic stress disorder or a lifetime prevalence diagnosis is really matches a lot of other studies. So then we can see that the kids with ASD having twice as much is a really important difference. This is also the first study to examine the relationship between adverse childhood experiences and post-traumatic stress symptoms in ASD youth. This has been looked at a bit in adults, but not in youth. We see here that we are confirming some of those previous studies in adults that that there is a relationship, and then also confirming previous studies that youth with ASD have significantly more ACEs compared to their typically developing peers. And as hypothesized for both the ASD and TD youth, typically developing youth, more ACEs predicted more post-traumatic stress symptomology overall. And then this relationship between the ACEs and post-traumatic stress symptoms was differently related to externalizing and internalizing behaviors for the groups, the youth with autism versus the typically developing youth. And the autism group, we really saw a lot more externalizing as being a part of how ACEs led to, was related to more PTSD symptoms, or above ACEs, more externalizing was related to more PTSD symptoms. Whereas in the ASD youth, it was really, or in the typically developing youth, it was more internalizing behaviors. And that's interesting in this group of 10 to 11-year-olds, and speaks to some of the data we have about while anxiety and internalizing disorders are very highly prevalent in youth with autism, we also know that emotional dysregulation and externalizing behaviors are the issues for which these kids come to treatment, to psychiatrists especially. And it's, if you think about it, it's actually the only treatment that is the only pharmacological treatments that we have for autism that are approved by the FDA are actually for the treatment of externalizing behaviors. So Risperdal and Abilify being used to treat irritability and aggression in youth with autism is really, getting at that externalizing behavior. And so that seems, we know that externalizing behaviors are really prevalent in this group and are a big part of dysfunction for these youth and their families. So we also found this interesting relationship between atypical functional connectivity between the emotion regions, the left and right amygdala, and primary sensory areas in relation to the most post-traumatic stress symptoms. And there are a number of ways we could think about what this means, but especially for the relationship in the right amygdala with sensory areas, the idea that more sensory to amygdala connectivity is associated with more post-traumatic stress really fits a model coming out of our lab and others that there is hyperconnectivity between sensory regions and limbic regions in autism spectrum disorder, and that this is maybe the cause of some of the social problems that we see, which is to say that early on in development, babies with autism are actually having more sensory input and are having more connectivity with sensory regions that is making that input more salient to them. And then they are not responding as much to social cues in the way that they should be learning them, because that other sensory information is either too overwhelming for them or interesting in some other way, and that could actually lead to some of the problems we see down the line in developing other comorbidities, as that anytime that sensory information is too prevalent. There are also plenty of other ways too that we could be thinking about that. Future studies for this particular problem really need to evaluate how post-traumatic stress symptoms can arise in response to non-DSM criteria stressors, which are especially important to consider in individuals with autism. Freya Rumble at the King's College London has really done some interesting work in talking to adults with post-traumatic stress disorder and autism about the things that are that they consider traumatic, and sort of talking to them about their DSM-5 and non-DSM-5 traumas. And so they'll say that like the diagnostic process of being diagnosed with ASD was traumatic. Some experiences of therapy have been traumatic, that there are many sensory experiences that are very overwhelming and scary for them that neurotypical people do not seem to find as scary. So that we really need to be thinking a little more broadly about what trauma means for neuroatypical people. And that might help us understand better this relationship between other kinds of stressors and post-traumatic stress. So then I wanted to talk a little bit about sort of the broader implications of this externalizing and behavior and oppositional defiant disorder. This is something that I am interested in studying down the road and learning more about. We know that irritability and disruptive behaviors are core features of externalizing disorders such as ODD. And they're also highly associated with ADHD, adverse childhood experiences, including, all the things we talked about here. And the diagnostic patterns indicate that irritability and these externalizing symptoms are more often interpreted as being disruptive in Black and Brown youth who receive fewer ADHD or DMDD diagnoses, fewer affective or anxiety diagnoses than their non-Latina white counterpart youth with similar symptoms. So I think it's really important to think about what these externalizing behaviors may be meaning. And we know that youth diagnosed with ODD are likely to have underlying anxiety or mood symptoms that are predictive of anxiety and depressive disorders in adolescence or adulthood. In other words, kids with externalizing behaviors are more often to go on to develop internalizing disorders in adulthood than they are to develop conduct disorder or antisocial personality or some other issues. And that's really important for us to think about in terms of both what might be causing the externalizing behaviors and how we should treat them. We know that while for ODD, parent training is a go-to for treating kids with oppositional defiant disorder, we often sort of go straight to that without addressing what some of the underlying issues might be for that particular kid to be expressing their emotions in that way. And we really should be thinking about adverse childhood experiences in what could be traumatic for that kid, even if it's not considered to be DSM-5 qualifying traumatic. And the underlying depression and anxiety symptoms that they might have that's just showing up as something that is more in your face and disruptive than the kids who are avoidant and anxious. So I think this is something that's really important to me, both in the way we look at it from a social justice perspective and the way we treat the people coming to us individually. Particularly for youth with ASD, I, for one, have had many patients come to me who have made it into adolescence with diagnoses of sensory integration problems, oppositional defiant disorder, and don't have a lot of friends or something like that. And it turns out that really the thing that best encompasses all of their issues is a diagnosis of autism. And if we could understand how that affects them and their oppositionality or defiance, that would probably help them and their families a lot. So this is something that I'm interested in studying more broadly going forward. More specifically, I love the slides that PowerPoint makes. Future research with all these graphs. So my future research will involve lots of fancy graphs. And so one thing that we study in my lab is sensory overresponsivity. We already talked about ASD a bit, but just to be more clear about what sensory overresponsivity is. It's when someone is distressed by and avoidant of certain sensory experiences that neurotypical people usually don't find upsetting, such as sirens or tags in clothing. And as many as 75% of individuals with autism have sensory overresponsivity. And it's very distressing and causes a lot of avoidance that impairs daily functioning for these youth and adults. So the labs of Doctors Green, DePreto, and Buchheimer have done foundational work in understanding the neurophysiology of sensory overresponsivity, and some contributory patterns have emerged. We understand that there are bottom-up processes of systemic hyperarousal and neural hyperactivity in primary sensory and emotion brain regions. There are top-down impairments in modulation of sensory input and emotion regions, and problems regulating and inhibiting behavioral reactions to strong, unpleasant emotions. In my next project, I'm going to be using transcranial magnetic stimulation to see if I can affect the circuits involved in these processing loops, to see if I can eventually help people with sensory overresponsivity have fewer symptoms. And just to get us on the same page, TMS, or transcranial magnetic stimulation, is a non-invasive therapeutic technique that uses magnetic fields outside the head to produce electrical current in brain tissue. We can really get only as deep as the outer layers of cortex with this, but there's lots of evidence that it's very effective in people with depression, and I now work in the TMS clinic, and there are thoughts that maybe it could be useful for other people as well. So when we have looked at neurotypical individuals with depression and studied the effects of TMS, we found that there was improved neuroplasticity, alterations of neural circuits, and changes in the excitatory and inhibitory balance that came with symptom remission. And each of those mechanisms actually are related to things that we see in sensory overresponsivity from our research. So for example, I recently demonstrated that sensory overresponsivity is related to an imbalance of excitatory and inhibitory neurotransmitters, glutamate and GABA. In particular, I was looking at the thalamus and sensory cortex, and that the elevated glutamate may be a cause of impairments in bottom-up processes through the sensory cortex, whereas decreased thalamic GABA may alter functional connectivity associated with top-down processing. And so these are some of the ways that I think that by doing TMS in the corticothalamic loops, I might be able to affect this system. So I'm doing a pilot study coming up with one session each of both excitatory or facilitatory and inhibitory or suppressive TMS. And I'm going to be doing MRI scans with functional connectivity, sensory habituation, and the GABA and glutamate scans, and looking at their autonomic arousal and their sensory sensitivity. And I'm just starting with young adults because they're easier to consent to do TMS. And I think that we're going to be learning a lot. So I just got a grant for this, and that's very exciting. So that is what I have. Thank you so much for listening all the way through. And I'd like to thank my lab and my mentors again. Mirella and Shula have welcomed me, and it's been a great place to work the last couple of years, and I'm excited to be coming on as faculty.
Thank you. That was wonderful, Emily. I have like a million questions for you. I think I'll have to ask a lot of them offline, but I'm really excited about the work you presented. If everybody wants to put anything in the Q&A, I'll read the questions for Emily and she can answer them. And in the meantime, I will throw a couple of questions at you, or if they're quick, then just one. What this is not going to be a well-formed question because you just triggered this thought in my mind at the end of the talk, but I think a lot about the EI balance in the whole corticothalamic striatal loops with Tourette, which in some ways is like this, dysregulated output, and you're kind of talking about a dysregulated input. So I'm really seeing a lot of overlap there, and a lot of our Tourette kids have this sensory sensitivity issues too. We see a lot of the same kinds of sensory sensitivities and that parallels. So I'm just thinking about the overlap between our the areas that we study. What are you going to like? So how in thinking about would this kind of intervention with the TMS work for Tourette? I know that our literature so far is not very great for TMS in Tourette because they're so deep, the areas that you would have to target. So how are you getting around that? Are you doing more of the top-down sort of regulation? I don't know.
Yeah, so I think there's, when I talk about top down and bottom up, I think there's multiple things happening with sensory overresponsivity, and partly that's, and then the same thing can be applied to Tourette's. And that's, we see a lot of heterogeneity, even though, in these kids. We suspect, and based on some of the information we have about their sensory systems, that kids with autism seem to demonstrate that they actually are getting a different signal, right? Or a stronger signal, or more noise, or these sorts of things, right? So that's like the bottom up processing and it might be that the Tourette's kids are getting that as well. But then the other part that we share with Tourette's then is how is that modulated? So all of us normally have a habituation system that allows us to like sit on a chair, and when our butt hits the chair, we know where we're at, but then we stop feeling the chair after a minute, or we put on our clothes and we might feel a tag at first, but we habituate to it quickly, because if we don't, we will be stuck on all those little bits of information and we'll not be able to focus on the things that we need to focus on. So it seems like that that is a really crucial piece that we're hoping to be able to modulate a little more, is helping kids or young adults learn to habituate better. And while that is expected to be currently an unconscious process, we may be able to strengthen the circuits that are related to frontal connectivity with the amygdala and the thalamus to strengthen the ability to habituate and then control reactions.
Cool. Would the same thing work for our Tourette kids, you think?
Maybe. I think a really key thing about TMS that I'm both excited about and wish that we knew more already, is that we, just as with all the things we do in medicine, the parameters we're using right now, for instance, for treating depression in TMS are, like we came up with some and we were like, yeah, let's do like 10 hertz. That's how many fingers we have, right? And then we did that and we found like, oh, that's excitatory. And what if we do 1 hertz? Oh, that's inhibitory. A lot of the things we've come up with have not been studied in terms of like a spectrum. And so we have some, so just like the same with drugs, we're like 40 milligrams of Prozac. That's the one. We know that doesn't work the same for everybody, and that we expect that because we are tapping into circuits in the brain, that people, fire at different frequencies, and that we've seen already that adolescents with depression don't respond as well to TMS as adults, and I suspect that that's because they're not fully myelinated. Their brains are actually different. So I think that what we're going to find in neuroatypical people is that the first part of the study that I have to figure out is whether or not the same settings even cause the same basic changes. And that's where we're starting.
Great. Okay. Well, we got a few questions that came in. I gave people time to type their questions. So from Dr. Natalie Ramos, Amazing talk. Excited to work with you in the future. What you've got some collaborators coming, I guess. What are your thoughts on the overlap among neuro and gender diversity in general, and specifically in terms of the traumatic impacts among youth with ASD?
Yeah, so this is something we talk about a lot in the ASD clinic because we are seeing so many kids coming to us identifying as non-binary. And we wonder, the question is, just as anytime we see a huge sort of increase in the rate of something, is it because it's actually happening more, or is it that we now have a way to describe it and talk about it, and kids can, because we are now talking about being non-binary and not having to fit into traditional female male roles, that kids are able to express this. So I think that that's a huge part of what we're seeing. This is becoming mainstream for our kids, especially in a place like Los Angeles, that they can identify this way. I think that what you are also seeing in possibly with these increased rates in kids with autism is that they are generally not feeling like they fit into the world in a lot of different ways. And fitting in terms of their gender is a part that then just kind of matches those other ways that they don't fit. They're already understanding that they're different. So it's easier maybe for them to, sort of pick out like, oh, I don't fit in this way either. The flip side of it is that they're looking for a way to describe how it is that they don't fit. And maybe this is one thing that might help them understand. But trauma, traumatic, in general, I think trauma is more related to the experience of people living in a world that does not allow them to be themselves, which for kids with autism is not just related to their gender identity or as being non-binary as it is to other aspects of them. So another thing we didn't sort of talk about in terms of what is traumatic for people, but is traumatic for individuals with autism is just constantly having to camouflage and not be authentic. And that's something that we see in gender nonconforming youth who are, it's really a lot of work to live in a world like this. So I think that actually that's where the trauma comes from. I don't think and I think it can be much more traumatic for kids with autism as they are less able to handle bullying. Unless they take peers, I highly recommend peers, and they can learn to do their eye roll. It's really hard to learn. But I think that's where the trauma plays in. I don't know if I answered that at all, but.
Great. I've got a, excuse me, I've got a multi-part question for you from Dr. Michael Strober. I'll give you the first one. He says, thank you, Emily. Given recent GWAS data showing considerable gene sharing across clinical phenotypes, and given that sensory overresponsivity is quite common in generalized anxiety in the absence of ASD, and that GAD has been associated with aberrant frontal limbic connectivity, do you think that sensory overresponsivity in ASD is unique in some way?
So this is a good question, and we are looking, it's not some of the work I have specifically done, but Shula is looking at how kids with anxiety and kids with autism differ in their sensory overresponsivity and in their levels of anxiety. And we do see some differences in what, like kids with anxiety are more likely to have sensory overresponsivity compared to the non-anxious population. And actually that's important to point out that sensory overresponsivity or sensory issues are not just in ASD. They're higher in ADHD, anxiety, and other issues. So there is a higher rate in kids with anxiety disorders, but the way that they manifest is often different. And I think that the underlying neurodevelopmental pattern that we see in kids with autism that's starting so early with their sensory system being abnormal compared to neurotypical individuals suggests that there is something unique, and that some of the same mechanisms that I was talking about earlier about how we regulate our emotional and our behavioral responses to that input is probably very similar. So that is probably where the pathways converge a lot. And another convergence is sort of the arousal feature. We know kids with autism are, in general, have more sympathetic tone, just as some kids with anxiety do. So, and less parasympathetic regulation of that. So there are definitely similarities, but I do think there is something unique in autism, or that kind of neuroatypicality.
And then the second part, given the sensitivity to change or novelty in ASD, similar to what's observed in anxiety disorders, have you examined hippocampal activity in ASD?
I have not examined hippocampal activity. That has absolutely been examined in kids with autism, in trying to understand their discomfort with uncertainty. And there is some evidence at sort of a very broad level of there being a Bayesian learning difference in kids with autism, in that they are taking, they're using new information or weighting new information too much, and that is part of what leads to the difficulty with changes, because new information is weighted in such a way that makes it even harder to deal with. So I think that that's not something I'm particularly looking at, but it has been examined.
Great. I'll ask another one while we give people like their last shot at a question. When you showed all the data that you'd gathered about the amygdala reactivity with regard to the trauma symptoms in ASD versus controls, how consistent are the patterns you're finding across your autism kids? Like, are they all showing these kinds of, there wasn't p-values, so I couldn't really tell.
Oh, sorry, yes. So all the ones I showed were significant differences, significant interactions. But because it's hard to show because I'm doing above and beyond, it's hard to show where the points lie. So, it's still a very heterogeneous group. And this is actually another line of research that Morella is working on, and I'm working on with her, is really understanding which part of the circuit might be different for different kids with autism. Because we know they all look very, very different. And I think that also ties into what Mike is asking about, which is like this, we know that there's almost as much heterogeneity amongst this group, and in, as we see between, ASD and anxiety. So what's what? And no, we still have a lot to figure out in terms of what for each kid is making them tick. And that's a whole nother line that I'm interested in understanding. Like for the TMS, I suspect that I will find a subset of people who will respond well to TMS, and that it won't be everyone with autism will respond to the one kind of TMS. That's absolutely not expected.
And then just maybe I may be the only one who missed this, but in the observation you had about the expression of the trauma symptoms as in an externalizing way, which I think is really interesting, are you able to say that's specific to a trauma effect, and it's not just that there's a higher level of externalizing symptoms in ASD kids in general than there are in the typical population? Are you seeing something uniquely related to the trauma?
So in this case, I'm relating it to so there wasn't an interaction with adverse childhood experiences. So I can't say that there was something that was particularly more, that more externalizing is necessarily related to more trauma in that way, if you're talking about this sort of little t trauma. Because in terms of big T trauma, DSM-5 trauma, I was only looking at kids who said they had one, so I can't say anything about that. But it is still interesting that even, I mean, we saw this, strong relationship between adverse childhood experiences overall and post-traumatic stress symptomology. And even above that, we're seeing only in the ASD kids that externalizing symptoms are more prominent, whereas it's in the neurotypical kids that the internalizing symptoms are more prominent. Does that make sense?
Yes, but what about also including the kids with autism who didn't have trauma to see what how that compares to baseline externalizing, and if you're getting an increase in externalizing when the presence of trauma exists?
That's a good question, and I haven't looked at that in absence of the PTSD, so I would have to look.
Could be an interesting addition, because I think
Mhm.
it's a really cool observation you made about the externalizing. Anyway, I think we're at the end, and I think this was a really great talk and a fun discussion, and I'm really happy to have been part of it. Oh, did we get any more questions? Oh, I sorry, we did get another question. Shoot, it just popped up. Um, well, Elizabeth Lageson thanks you for your important work and welcomes you to the faculty. Real quick, Dr. Catherine Lord says, Emily, a great talk and a wonderful direction to go in. I'm wondering how to apply your ideas to working with young kids and families with autism. Do you have ideas about trying to prevent early little T trauma? Obviously, big T trauma too. Kathy.
So that's a great question. So firstly, in terms of ACEs, I think that's a societal level kind of problem, right? Um, there's not nothing, but as a clinician, I can't just be like, well, could you have fewer family members that are getting arrested and being jailed? That would be better for your kid, because that's not a thing we can do. And that's actually something we need to work on in terms of social justice and our criminal injustice system, for instance. But in terms of thinking about the stuff that may be traumatic to kids with autism that we wouldn't necessarily be thinking of that way, like their sensory experiences, I think that is something that can be discussed with parents and just bringing, I mean, I actually think the trauma-informed mindset that we try to use with kids who have trauma is really appropriate to use with most all of the kids we see, which is understanding that there might be experiences that are really hard for them to talk about, or that even the experience of being at the doctor and talking about the stuff they're talking about is really scary. And so when we approach them, we need to understand that they are experiencing a lot of fear and anxiety. And if we can understand that their reactions to us are often coming from a fight or flight response first, then we're going to have an easier time recognizing that they really are doing the best they can, and that we might need to think about how we are eliciting that response in them. So I think that's the takeaway for working with younger kids, is that and some parents get this naturally, they try to avoid loud places, and when their kid gets overwhelmed by loud noises, they give them some time to cool down and all of that. But some parents say, what do you mean? It's not loud. It's not loud to me. It should be fine. Right. So that I think is the piece that we can help families understand, that it really is different for that kid, and it may be actually traumatizing at some level for them.
Great. And you still have almost 20 people here after 10 o'clock. So clearly that is evidence that people are engaged and interested. Thanks so much. Thanks everyone for coming, and Emily for giving an amazing talk. And you need to teach me how to use those, find those PowerPoint pretty slides, because I don't know where you found them. I need a tech consult, please.
Will do.
Thanks everyone.
Thanks.